Welcome, and thank you for joining webinar 2 of a 4-part webinar series titled Self-Testing Strategies for HIV Testing and PrEP. My name is Kendrell Taylor. I'm a manager on the prevention team here at NASDAD. The series aims to share models and innovations from health departments about implementation of a range of self-testing programs. The series will discuss public health implementation models, which include outsourcing self-testing to a commercial vendor, delivering services through a current public health infrastructure, including CBOs and state public health labs, or a mix of both. In this session, we will focus on approaches for clinical decisions regarding self-testing for PrEP and lessons learned when implementing self-testing within various populations. Our colleagues from Washington University in St. Louis, Emory University, and Cook County Health in Illinois will guide discussions and answer questions. This webinar will be recorded and posted for future access. We will also have a chat function available and invite you to please use this function for any questions or comments during the webinar. We will have about 15 minutes at the end of the presentations to answer some questions and have a live discussion. Questions at the end, questions asked during this session will be compiled, answered, and sent with the recording of the webinar and posted onto our website at NASDAD. Before we get started, we have Maria E. Alvarez from CDC, who will say a few words about our partnership with CDC. Maria?
Thank you, Kendrell. Can you hear me?
Yes, we can hear you.
Excellent, thank you. So, good afternoon, colleagues, recipients, and partners. On behalf of CDC's Division of HIV/AIDS Prevention Program Branch, Ms. Erica Dunbar and I, Maria E. Alvarez, would like to welcome you all to today's webinar on self-testing strategies for HIV and PrEP access. As Kendrell stated, today's topic focuses on implementing self-testing for HIV and PrEP monitoring. Our renowned presenters will discuss approaches for clinical decisions regarding self-testing for PrEP and lessons learned when implementing self-testing with various populations. Thank you for joining us today. We appreciate you taking time out to attend the second of our 4-part TA webinar series. Also, a special thank you to our partners at NASDAD, who in collaboration with CDC and other federally funded CBO providers continue to plan and provide intentional state-of-the-art technical assistance webinars to demonstrate our commitment, collaboration, and support towards the HIV prevention workforce, partners, and communities as we continue to work together on ending the HIV epidemic. A big thank you also to all who participated in the 4 CDC regional community engagement town hall sessions 2 weeks ago in November. The virtual town halls were a huge success with over 850 partners and community members in attendance. The town hall sessions provided an opportunity to educate and empower the local community on the engagement and planning process for the federal EHE initiative. It also provided a safe space for community members and new voices to share local EHE experiences and make recommendations. As I get ready to turn it back to NASDAD, one last quick reminder to our 1906 recipients. Please note, updated EHE plans and related documents should be sent to the PS 19-1906 at cdc.gov mailbox by December 31st, 2020. For reminders and updates on the EHE plan submission requirements, please refer to the October 22nd PPB News Communication Blast or contact your project officer. If there are any questions specific to 1906, please feel free to submit them to the PS 19-1906 at cdc.gov mailbox. CDC remains committed to ongoing partnerships and the provision of technical assistance services. Thank you again for attending today's webinar, and please continue to stay safe. Back to you, NASDAD.
Thank you so much, Maria, for that overview and introduction. Next, we have Dr. Rupert Patel from Washington University in St. Louis, who will be discussing clinical decision-making surrounding self-testing for PrEP during COVID-19. Rupa?
Yes, thank you. It's a pleasure to speak, and thank you for the invitation. This is a urgent topic, so we're excited to present. Next slide. So I'll be starting out with the clinician hat and a capacity builder hat, with just describing PrEP when we say the word PrEP, so we're all on the same page, and then going into how that care happens as standard of care, but then how can you take elements of the standard of care and adapt certain portions of it to meet the needs for social distancing with COVID-19, and then thus home-based care and essentially telecare. Some of the lessons learned through our own program and through our work at the Capacity Building Agency at Washington University in St. Louis, and then to top off the talk with some briefly to describe some resources available. Next slide. So I just wanted to, as a clinician, seeing patients, it's important to understand that people will come in and say PrEP, and they may mean on demand now, they may mean daily PrEP now. And so those conversations are starting to happen when we talk about PrEP on initiating, follow-up, and restarting. And I'm gonna say those words a couple of times because that's how we have to categorize the visit, then the test related to that visit, and then the follow-up related to the visit, and the clinical resources related to that visit. And so for the purpose of this talk, we'll be discussing the FDA approved and CDC guidelines related to daily oral PrEP with FTC. And then we know that tenofovir associated, tenofovir alafenamide based PrEP is also available. And the conversation about the different type of PrEP of stopping and starting and on demand is realistic. It happens in clinic. I won't go through all of that, but that is something that providers need to know and program managers need to know about the resources they need for their clients. Also, in the scope of the talk, I don't have time to go through the wonderful website of AIDSview and to highlight, the disparities in access, but the conversation today also has to revolve around how are we maintaining the offices that we had through telemedicine, et cetera, and home-based testing to continue to reach the individuals we need for offering PrEP and testing. And then remember, access to PrEP will always mean office visit, labs, and the medications. And I don't want to decouple what I'm saying today about clinical decision-making and HIV self-testing and other home-based testing and the PrEP care process without acknowledging that everything requires an office visit and a doctor, a lab visit or a lab access point, and then the medication access point. Next. So I'm going to take you to our standard 2017 guidelines by the CDC, and I want to highlight the clinical eligibility portion that's circled in red, and then the prescription, and then the other services. Again, we've talked about initial care and then follow-up care, and I want to highlight at this time we're seeing a lot of restarting of PrEP due to loss of insurance, and then somebody that cannot get that care, get that medication at the pharmacy, and so your clinical visit may surprisingly be the following on an initial intake is that I was on PrEP, then I got off of it because I lost my insurance or I had another type of interruption. I don't think I needed it. And then in general, or it may be that I'm on PrEP today in terms of your initial visit, and then your follow-up will be the same thing. Someone may be maintaining their PrEP care with you on that routinely scheduled visit, or it may be that the visit has turned, the corner into a different flavor for that visit of, I had to stop or I didn't think I was at risk. And so these are the elements of where your testing will fall into. I want to make sure with standard of care, we've always been talking about a really good history for acute HIV to document the window period. And then the tests that couple HIV testing, which is renal function and the other tests that are very important as part of PrEP care, which would be hepatitis B, hepatitis C, and STDs. And next slide. And I want to transition to when we talk about standard of care, I want to advocate for and also highlight that even if you were prescribing same-day PrEP, it is possible with all the new modalities and testing to preserve that. So this is an article in HIV Lancet describing same-day PrEP care, and I wanted to use this platform to also highlight that same-day PrEP is something that most programs are thinking about. It's a way to advocate for easier access, as I talked to on the beginning slide about the background on where PrEP provision is falling short of the people who would benefit it and the estimated need. And so what I want to highlight is same-day prescribing is different than same-day starts and getting that medication in your hand. And you'll need to tease out same-day PrEP when you start thinking about the lab tests. So now I want to transition to the next slide on just adaptation. Now we've set the stage for what is CDC guidance, what is the standard of care, and what are some adaptations to the standard of care even before we reach COVID. And so this is another great graphic by the CDC on their effectiveinterventions.org. And coupled with this exact website, I want to highlight there's a letter from the CDC specifically outlining the 2 types of HIV testing and also HIV testing in the context of PrEP. And we'll be reviewing that on this slide as we talk about adaptations. So on initial clinical evaluation, the context has to be in also the clinical decision-making around PrEP and HIV testing is evolving, it's emerging, there's no correct answers. I wanted to advocate that basically this different modalities of testing are very important to making the menu of options so that you can meet your client's need during COVID, as well as the provider access to COVID, you know, providers coming in and out to staff hospitals or having to be pulled somewhere else. In addition to the staffing of your clinic. And an example will be that clinics closed and a lot of things were done virtually to make sure people didn't have their care interrupted. So prescriptions were extended or self-testing was offered. And that was to make sure we could keep people on PrEP. But then clinics are now opening and implementing in a very rapid pace the following: TelePrEP or PrEP in person for the first visit, and then some hybrid model of remote testing and remote electronic interactions with the provider, and maybe coupled with in-person if a physical exam needs to be done, coupled with the staffing that's coming in and out, or if a whole bunch of staff have been exposed to COVID and coming in. So what I wanted to advocate in this webinar is really important is that early on, lay out a menu of options for testing and teleplatforms and hybrid models for in-person, so that you can, your office, your nonprofit, your CBO, your health department can be adapting to all the situations that have happened in the past, now, and with the surges in the Midwest where I reside, where we're going to have fluctuations in clinics being opened and staff being available. So in terms of the first test, I want to highlight some key important things. The initial visit is the initial visit. We always do look at acute HIV. In terms of lab testing, in guidance with the CDC, it's really important that we try to foster 4th generation testing, antibody antigen-based testing, to narrow down that window period, as well as to couple it with a great clinical exam and history related to sexual history, last exposure for HIV, and where that person falls into addressing their window period and follow-up testing. And I'm basically in the first circle on this slide of what labs do you really need. And it goes back to the menu of options. So in general, we've seen a lot of models evolve at health departments, nonprofits, and clinical providers like myself, where possible, we're trying to get on the first clinical visit a fourth generation test through a blood draw or through a home-based test, with which Pedro and Aaron will also go into, but also molecular diagnostics lab, as issued in the letter by CDC, has dried blood spot testing with fourth generation antibody and antigen testing. And, you know, in cases where I personally and other doctors have not wanted to prevent somebody from starting PrEP when they were recently tested, or there was a context where the clinic shut down immediately during the pandemic, a backup or the next option would be the OraSure oral swab testing. It is the only FDA-approved test at this point for self-testing. And what we need to highlight about that particular test in this particular portion of PrEP care, which is initiation, is that that window period is 90 days. And so when you go to, on this graph, part 2 and 3, you might want to consider, where is your follow-up testing if I'm using an OraSure test? And I've put in the middle, you might want to start considering 1-month follow-ups so that you can narrow down that window period if all you have an option is the OraSure test. And then you want to think about you know, your follow-up in general. So now a follow-up appointment is essentially defined into true follow-up at that 3-month mark, but you can place different types of follow-up at 1 month before that, depending on the tests you are conducting. So let's talk about HIV testing at the follow-up, where the circle is on Roman numeral 3. Do you want to use an OraSure test? Do you want to use DBS testing? Do you want to use any type of in-person lab? Again, it's up to you. There are 3 options laid out to really honor social distancing and not trying to bring healthy individuals into a clinic or into a lab. You can start looking at these modalities and then ironing out a good history and physical on acute HIV symptoms, restarting of PrEP. This is where I wanted to tell you, as a clinician on follow-up, be very keen on asking about if someone stopped PrEP. We look at stopping PrEP for more than 2 weeks to start thinking about where someone may need to be restarted, and we need to think about now start obtaining an HIV test with a very narrow window period, so really prioritizing blood draws, finger sticks, and 4th generation testing for that modality, and then the follow-up related to that. In this diagram up here, I want to just comment on creatinine testing. You know, kidney testing has been you know, a debate between many physicians about same-day PrEP and follow-up. CDC guidance is at time 0 or a baseline at 3 months and every 6 months. I do want to let people know it's every 6 months. This has been a point of where primary care providers sometimes have gotten lost in the guidelines, or there's been misconceptions about when that creatinine test is needed. And in same-day PrEP, we believe that the creatinine test can be cooking or in the lab and drawn, but is not required in somebody who has no history of kidney disease to be able to hold PrEP. And so in this box in the middle, I've talked about case scenarios, because you start looking at age and comorbidities when you start talking about creatinine testing and clinical decision making in the diagram of PrEP care according to the CDC guidelines, again, which goes into initiation, follow-up, and I want to throw in restarting as another caveat. Next slide. I want to now turn our attention to this very busy slide. You're going to get these slides as an audience member, and this was because under the CDC CIBA funding, Denver PTC, Prevention Training Center, and Washington University CIBA conducted a survey among the 60 jurisdictions where we were able to reach during the time of COVID, 47 jurisdictions and CBOs and health departments, and we tried to figure out who was doing self-testing, how were they doing that, and what were the lessons learned. And it's very pertinent to put it in here because PrEP programming will rely on the common things that happen and factors that happen with self-testing. And an example is, and so I want to advocate for program managers in the group when we're talking about self-testing and some type of virtual or non-in-person platform, don't forget to figure out how can we tie in PrEP linkage to care and PrEP provision and the tele portions of that. And some of the key points I want to discuss is privacy issues, and this is lessons learned as through the actual interviews, but also as an implementer and a provider on a daily basis myself, is the privacy issues and stigma related to doing anything online and needing to not have the safe space of the clinics that people used to go to, and receiving something in mail and also having that capacity, whether it's a smartphone to do a TelePrEP visit, but also having a mailbox that's secure, so where you can get possibly an HIV test or a box, and then how does that box look like? We had several people discuss actually the lack of having safe spaces, and that no matter what, in-person safe spaces had to be made and pickup locations for testing. So, and this goes into distribution of testing, which is a point lower on the slide. How do you go ahead and distribute? Want to make sure that we know that there's mail-in through vouchers, through OraSure, and through molecular diagnostics. There is pickup locations, and then there's a delivery of a kit to a safe space. The other thing was accessing technology, whether you're talking about care, so HIV care, TelePrEP care, or actually the self-test. There were issues in obtaining the test when HIV testing was integrated into PrEP programs and separately, and that then causes an issue to time your self-testing and the results with your PrEP care and actually timing the prescription and getting that HIV test, which elongates the time of PrEP care. Many times HIV self-testing takes many days by the time someone receives a box and then reports back the test. Remember, that was taking about a week. I want to highlight in the guidelines for clinical decision making, if you have a test that's well beyond 7 days, then it's hard to identify if someone is tested negative and is actually picking up their prescription and then consuming that pill all within 7 days to ensure that an HIV negative person or uninfected person is actually taking PrEP for the goal of continuing to keep them negative. So when you're a clinician or a program manager, please space out the following items. The time you're speaking to someone and an HIV test is requested, they're getting it in the mail, they're taking it, they're reporting their results, you're getting those results, you're prescribing that prescription, and then they're picking up at a pharmacy, and then they're taking that in within around 7 days from the time of testing. So that's been very hard to do, and that's why you'll have to bridge some things with in-person testing, a lot of communication, and then this goes back to what are your staff resources. And then I want to highlight the last portion on this slide is linkage to care. One of the lessons learned is please iron out how you're going to have linkage to care. I want to remind you with the OraSure test, there's a higher number of false negatives and positive just due to the sensitivity, along with a longer window, a period for HIV. And so how are you obtaining confirmatory testing and linking in a reasonable amount of time to repeat testing and confirmatory testing, and then PrEP, PEP, and then HIV treatment? I want to go ahead and segue to the next slide. So in terms of segueing from the lessons learned on that busy slide and just the key points, This will all be nicely laid out in the resources of an executive summary that's posted on this website you see here, where in fact we have all the different program components, the 12 program components identified as how programs were stitched up for HIV testing, self-testing in the context of HIV and PEP and PrEP care, including sample clinical protocols shared by the programs of CBOs, health centers, and health departments. And just to highlight, 3 programs emerged where program managers can call, and that was the Baltimore City Health Department as a health department, Equitas Health, and Atlanta Harm Coalition that also couples testing with syringe programs and IDU populations. So these are the resources that will be available within a month. And then the next slide, please. We've also coupled this with some TelePrEP specific, not telehealth, but actually turning telehealth into TelePrEP resources that WashU has combined with a telehealth company, Prime Health, to really hone in on all the sectors you need for TelePrEP, and then the integration of the labs related to having a successful PrEP program virtually and in hybrid, in person and virtually. Next slide. And this is a reminder of how you can contact a community, capacity building agency assistance program through your health department and through directly contacting the CEBA CPN network. Thank you, and I'm going to transition back to NASTED.
Rupa, thanks so much for that wealth of information. Lots of that can be used to build or enhance many programs, self-testing, and even PrEP programs going forward. As we move along, I'd like to introduce Aaron Siegler from Emory University, who will be discussing various self-testing research models and lessons learned from various focus groups while implementing self-testing models. Aaron? Aaron, if you are speaking, we cannot hear you. Give me just a second, just have a little audio issue. Okay.
Can you hear me now?
Yes.
Okay, I think I was muted. I was system muted.
No problem.
Or maybe I muted myself unbeknownst to me. All right, but everyone can hear me?
Yes.
Great. Okay. Well, let me repeat myself to myself. Hi, everyone. I'm Aaron Siegler. I'm honored to be here today to talk with all of you about some of my research on PrEP care and TelePrEP. Thank you very much. And I'm at Emory University. Next slide, please. Okay, so even before COVID, PrEP discontinuation was a really substantial issue in the United States. So here's a pharmacy data set that I looked at with some colleagues at Walgreens. And here we see that individuals with, we classified periods of adherence or persistence in care, and people who had 3/4 of days covered were counted as persistence. And what you can see is that the year 1 discontinuation rate was 44%. The year 2 discontinuation rate was 37%. And so overall, after within a 2-year period, you're seeing the substantial majority of individuals discontinuing PrEP, and this is pre-COVID. We can also see that in the chart that there's this discontinuation is not equivalent. I showed this by age, but we could also look at by other variables, such as other studies have shown race, other key variables where we're seeing even higher rates of discontinuation, often among those most in need, in this case, younger individuals as well. Next slide, please. Okay, and another thing also pre-COVID is that we saw what I've termed PrEP deserts, and these are areas where people have very substantial commute times to get to the nearest, the geographically nearest PrEP provider. And this is especially an acute issue for people who may need specific services. So people who on the left, you see PrEP navigation services times the nearest navigation service provider, and that's insurance, navigation, etc. On the right, you see for services that would cover persons who are uninsured. In each case, these maps, the darker colors indicate longer drive times. And there's a pretty substantial body of research that shows that if individuals are not particularly willing to drive more than 30 minutes to primary care one-way drive, and you can see that there are well over 100,000 PrEP eligible MSM who are facing drive times of greater than 30 minutes, and even substantial persons who face drive times of greater than 60 minutes. And separately, I've recently done some analyses by public transit, and you see similar things within urban areas as well, just with really long public transit time. So even before COVID, we were seeing really substantial access barriers to PrEP care that that telemedicine might be helpful for. Next slide, please. Now, I just wanted to kind of bring up a general prevention care. This is a recent publication in JAMA that looked at the combined primary care office-based and telemedicine visits, both pre-COVID and during the COVID pandemic. And what we see is the 2018 through 2019 period and the early 2020 period, you're seeing more visits, right, like around 120 million, and then you're dropping down substantially in this Q2, this kind of new era of COVID. So there are fewer visits for primary care, and then also really substantially decreased levels of key assessments that would be harder to do with telemedicine care. So you can see there's a really large drop-off in the amount of blood pressure recorded, cholesterol assessments, etc. And then additionally, that has downstream ramifications for new treatment visits for kind of across the board conditions, everything ranging from hypertension to asthma. And the reason I wanted to show this slide was just that I think PrEP is probably situated well within this continuum of both fewer, it's a primary care office visit-based service too, and it is something that I think we're going to see fewer total visits initiated, and then fewer PrEP treatment visits initiated as well within that kind of overall decreased flow of patients. And so within that, given those two barriers, I think we really have to think critically about how we can make the services that we're offering as accessible as possible. Next slide. All right, so I like to think about TelePrEP as a kind of continuum. And if you think about kind of standard of care PrEP, a 0 on the TelePrEP continuum, you'd have an in-person visit where a patient sees their doctor. Between visit communications are kind of mixed, predominantly calls, but maybe some EMR records or text communication. And then the lab testing at those visits is going to be in person and often at the venue of care. And then we have kind of a middling level of TelePrEP. In this case, it might be an online visit communication, and even between visits it might be online, so some remote messaging. The labs are the sticking point in this kind of in-between model, and Rupa alluded to this as well. They're Some people have been doing home HIV testing to kind of alleviate this, but there's still some need for, to get the full lab array of labs, there's a need for in-person local lab visit. And then the highest stage of TelePrEP would involve a fully online set of services that would be online visits, online and messaging interfaces that target retention between visits, and then labs that are conducted at home. They're fully remote and they're self-collected and usually sent into an external laboratory for testing. And just to note that this TelePrEP, the high engagement level is frequently accompanied by kind of an attempt to have a different set of goals, which is really to overall increase retention in care above and beyond even the standard of care. Next slide, please. So about 5 years ago, we started research into TelePrEP, and this was in combination with a number of colleagues, including Dr. Patel and Ken Mayer, Patrick Sullivan, Leandro Mena, and others. And so when we first started looking into this, we wanted to kind of decrease the overall burden of PrEP seeking, with the idea that having often young and healthy persons go to a doctor 4 times a year is a quite heavy burden. And so our idea was to initiate a low-touch, low-burden PrEP prescription system, and this would involve home testing for 3 of the 4 annual visits. And so the idea is that we mail participants a kit, they'd self-collect specimens, give them a nice video and a nice set of instructions. Prepaid mailer gets it back to us, to the lab. A brief behavioral survey is done, again, just allowing for a low touch. And if everything looks right after the results, both the lab and the behavioral survey results are reported to the clinician, the prescription can be renewed without any substantial engagement with the clinician. And then as engagement is needed, whether it's for a positive STI test or whether it's for an adherence issue or a side effect issue, that then the kind of care can be ramped up. Next slide. And so in our pilot test with 55 persons, the system performed very well. You can see the green are agree and strongly agree bars, and they really predominate people's ratings of the system, like whether they'd like to use it regularly, whether they thought it was easy to use, whether they're confident with it. But also, nearly 90% said they would like to use the system in place of their next in-person clinical visit. And then, surprisingly, 40% they'd be more likely to remain on PrEP if the system was available. And so the system is now being tested in a clinical trial where we're randomizing people 2 to 1 to the PrEP at home system or standard of care, and where that trial oversamples young and minority MSM to be able to determine intervention impact in those vulnerable populations. Next slide. So, our update on that trial progress. The cities are Boston, Atlanta, Jackson, Mississippi, and St. Louis. And we have 204 persons randomized. It's a diverse sample, and there's been lots of interest and good retention in the study. But these are still the early days of the trial, and COVID-19 really introduced some substantial challenges. So what we transitioned to was a fully remote initiation visit to allow people to enter into the trial without having to do a baseline study visit. And then we also, allowed for the control participants there's some bleeding over into the intervention arm because they're often receiving the kind of standard of care TelePrEP that puts them at kind of the middle category of that TelePrEP provision continuum. And we've also had all the study participants have been reached out to by the PrEP clinicians just to kind of check in. In this time, it seems that it's hard to stay in care. It's hard to stay engaged in especially in PrEP care when sexual activity may be waxing and waning in different patterns than usual. And so a lot of our study participants found it useful to have those kind of outreach from clinicians to discuss this new era and kind of their decisions to remain on PrEP, and our clinicians were able to encourage people to remain on PrEP even in these changing times. Next slide, please. So Rupa mentioned molecular testing labs earlier. Molecular we've been working with them for many years now, and they do hundreds of thousands of screenings of these types of tests with very low rejection rates, and they are available in most U.S. states and territories. And so here's the contact information for the molecular testing labs that we use for these study labs. They're really an excellent partner, and this way for prescribing purposes you can get all of the pieces that are needed, all of the labs that are needed, and still allow for kind of maximum convenience for participants. Next slide. As I think obviously everyone's going through a lot of changes in their general telemedicine procedures, and then telemedicine procedures specific to PrEP. And so just wanted to kind of emphasize the human-centered kind of concept of design. The idea here is that the user is placed first and foremost in design. And there are a lot of different ways to assess the acceptability of these new methods as they're being rolled out in institutions. So the first and most basic is just having like a hypothetical survey where clients might be asked, would you be willing to do this? Would you be interested in this? More advanced version of that is discrete choice experiments. That's more of a research assessment. You can also do quantitative ratings of persons after they've experienced the system. So there's some standard rating scales for these types of assessments that allows organizations to have a kind of baseline for what the scores mean. So systems usability scale is one that we've used previously. And then also those individual component ratings within each system, whatever system is being adopted by your institution. It can help to identify kind of problem spots. If you allow users to rate the individual components, you may find that there's a problem with a particular part of the system that's hard to access, and it's an easy way to identify that. And the last is qualitative observations. These are often really, really simple to do. Simply having an in-person observation of somebody undergoing whatever system you guys set up is being set up in your organization. And then that can be done either through remote video observations. We've done that in developing self-testing kits actually for COVID-19, or it can be done in person. And so those are often, the data collection can be comprised of checklists and open responses items. And these allow for kind of a rapid assessment of how any new systems are being used and kind of identification of areas for improvement. Next slide. So I want to talk a bit about another study that we have underway. This is with Landra Mena at Mississippi and part of the Adolescent Trials Network. And so the idea here of this study, this is pre-COVID, was to create a full telemedicine system in which a person would never have to leave their sofa. And so it's a fully app-based system that, and we've been randomizing people in this trial to either full TelePrEP or standard in-person PrEP care. I think there may be a few more bullets, but you can just run through them. The next slide. Yeah. And so we developed, for this study, we developed a mobile app, and that included both telemedicine consultations through the app interface, similar to what many EMRs offer, but also text messaging. And we built in surveys into the app, again, just to kind of streamline the process. And the system also includes automated reminders, which have proved really essential for persons who are doing PrEP in the virtual era, where it's easy to lose track of specific components of medical care with PrEP that need to be completed. And so That's an important component of the system. And then also we've included progress tracking within the app. And so you can see kind of on the right that people get check boxes when they have completed a key component of their PrEP service. And I mean, this is kind of a research-specific thing, but I think in general, allowing patients to have a clear pathway through their what they need to do to obtain PrEP and to succeed in a PrEP regimen in their medical care is kind of a good practice that will help increase compliance. Next slide. And here you can see kind of the theoretical model of this intervention, and we base this off of Anderson's behavioral model. And you can see a number of kind of human-centered design features that kind of allow for us to provide more wraparound care even in virtual settings. So, you can use surveys to kind of screen for things like mental illness and substance abuse that can then be referred out for additional services as needed. Okay, next slide. And here's just kind of an additional piece that, again, like we just sought to try to improve the way that patients can interact with our system by, rather than requiring people to like fax in documentation, just allowing people to use their smartphones to quickly get us documentation. And I think this is kind of a more standard practice now in the COVID era to allow for this kind of quick documentation. But I think it's really essential that we, if we design the systems with patients in mind, there are these kind of shortcuts to be had that allow people to complete the tasks on their end that are needed for care more efficiently and facilitate initiation of care. Next slide. And here you can see our kind of online scheduler, as well as kind of a notifications screen that of what's coming up in care. So this kind of seeks to streamline the task of the participant. All right, next slide. All right, and this is kind of the last one where we have like it's equivalent more or less to an EMR like messaging portal, and we use this a lot. It allows for us to do a lot of task shifting, and that really helps with care. I think it's really important to try to task shift off the clinicians who are doing a lot of the day-to-day activities of care, and allowing the other levels of providers to help participants stay engaged in PrEP care in these remote times. Next slide. All right, so this one it's a bit far off, but I wanted to kind of bring it up because I think as a theoretical model it's relevant. So this is a slide from a recent article published in mHealth, and what we were looking at was the difference between timelines of competing things. So on the one hand, you have a common grant-funded timeline that's about 10 years of development before a health process is ready for the market. On the other hand, you have a business implementation timeline of technology. A good example is like a PDA or some of the early electronic interfaces that people did use in research. And those often, by the time the NIH funding cycle was through, the technology was actually obsolete and off the market. And there are some interesting publications I was able to find where technology had gone entirely off the market, but people are still publishing saying we should be using this technology, it works. And I think this kind of, in the era of COVID, this kind of timeline mismatch is relevant because it's possible that it may take some time for organizations to kind of ramp up relationships, let's say like with molecular testing, that by the time that, a fully remote lab is ready to go, that some of the urgency of the COVID era may be over. But I think there are other benefits to kind of pursuing these alternative care options for our patients. And so, COVID is actually an opportunity for us to think about what kind of needs of our patients and of PrEP patients in particular are continuing, are going to be ongoing, and will be benefited from setting up these systems, even if they may not quite be ready to go as soon as we want them. And so I think there are a lot of continuing needs that can be addressed, even if we may not be able to fully implement systems in time for the COVID epidemic. Next. And last, just wanted to kind of go over how the importance of creativity in trying to reach clients, because a lot of our traditional models of reaching patients, I mean, as we saw, there are vast reductions in primary care visits for every condition. And additionally, I know, many of the community organizations they're doing outreach, that a lot of their in-person outreaches it's just not possible right now. And so I think, we need to be really creative about how we get prevention services to the persons in need. And so one model that we're using at Emory is we've collaborated with a platform called Blued, and Blued is the China equivalent of kind of a number of geosocial networking apps like Grindr, but they have over 12 million men in China using their platform, and these are groups of men who otherwise aren't, a fair number of them aren't accessing HIV prevention services otherwise. So if you look at the kind of chart below, you'll see that there's about 46% of persons who are not always using condoms, but among those, a majority, 27% bar of the total would be willing to order condoms through the Blued app. And similarly, a third of the group had not tested for HIV in their lifetime, but among that third that never tested for HIV, if they're offered home testing through the app, almost 2/3 would be willing to do it. And so, and last, PrEP, a lot of people hadn't heard of PrEP, but among those who had heard of it, nearly half would be willing to take it if offered kind of in a telemedicine platform through the app. And so I think we really need to think about what are the alternative models. How can we reach people who the services aren't currently reaching? If we're not getting to people through our traditional channels of community outreach, can we use social media influencers? Can we partner with app companies? Can we, look through other mechanisms? So I think it's really going to take, acknowledging that some of these older models they're just not working right now because of the current environment, and that we need to look for really thinking through critically what are the new channels that can be used to reach patients who might traditionally seek care at your organization. And so I just wanted to end with that if we are creative about our trying to find new channels, we may be able to reach previously untapped populations who actually are interested in receiving services. All right, next slide. And I have many acknowledgments of many wonderful partners for the clinical trials work, as well as funders at NIH and Emory and Matt Gates. Thank you.
Thanks so much, Aaron, for that. Great work that's being done at Emory. Lots of research and a tool of reservoir that many can go to for good information. Next, the last speaker that we have today is Pedro Serrano from Cook County Health. And Pedro will discuss various self-testing research models and lessons learned from various focus groups while implementing self-testing models. And I will leave it to Pedro.
Hi there, can you hear me now?
Yes, I can hear you.
Okay, great. So I correctly unmuted myself. Great. Good start. Well, good afternoon, everyone. Can you go ahead and move to the next slide? So I'd just like to introduce myself. My name is Pedro Serrano. I'm a project director here at Cook County Health in Chicago, Illinois. I specifically work at the CORE Center, which is a community health center of Cook County Health, and we are a clinical trials research site of numerous trials networks, and as well as a site of a number of researcher-initiated studies. Principally, the studies that I'll be speaking with you today are studies from our adolescent and young adult research studies through the Adolescent Trials Network and HIV Prevention Trials Network, as well as from a recent NIAID-funded epidemiology study called Keeping It Light. Next slide, please. So I'd like to go over some lessons learned from our HIV prevention research work with young people. And this is spanning the earliest adolescent trials studies on examining whether Truvada would be efficacious for HIV prevention, whether it would be acceptable and feasible to be used, implemented by youth, and in particular youth of color. And we learned a lot from the early studies on PrEP. We learned that as early as 2010, when we were about 10 years ago, when we were starting these studies, we were already moving to utilizing text messaging for recruitment and retention in terms of not only initiating conversations with our prospective participants, but then also maintaining that relationship with them as their time on the study continued. They were even then averse to phone calls or having us leave them voicemails and preferred that we simply message them. When we would not conduct your traditional street level and bar and club outreach in the late evenings, at gay bars in the neighborhoods, palm cards and other visual aids were particularly effective at being able to communicate in a variety of settings, and even bridging to bringing young people into the clinic space, making sure that there was a high visibility of friendly messaging signs posted throughout the building that welcomed them when they came. And even in the consenting process, using whether it be a slideshow on the computer screen or printed materials that break down the different steps of what it means to participate in research, the consenting process, the recruitment and enrollment process, and what it means to stay on board and or leave if they choose to. When we were recruiting for some of the earliest studies, we started looking at whether we could advertise on Facebook and Grindr and the like. And obviously that's been an evolving and now fairly standard practice in recruitment for these types of studies with young people. And that has, I think, really been a game changer for recruitment of what we used to call hard to reach populations. The youngest people of color at risk for HIV. The common language for that population in the papers were hard to reach populations. I don't think that that's as true as it was then as it anymore. And then I think social media advertising and as a recruitment method has really changed that. Now, something that we often do some consulting around when it comes to implementing, whether it be an HIV testing program, a PrEP program, or a research study with young people, is how do you implement a good strategy around social media usage? And I mean, number one, you do need to have your agency needs to have a strong web presence and social presence. You don't need to be everywhere, meaning you don't need to be on Facebook and Instagram and Twitter and YouTube, etc. You don't need to be everywhere, but you need to choose the channels that for the audiences that you want to reach. And these days, especially if you look at like Pew Research Center, they'll break down what age groups are where, etc. And you need to be a trusted voice. And sometimes, especially for a new patient, a new prospective patient who's not utilized services at your health center before, at least being able to be Google searchable and have that social presence makes you a more acceptable venue to receive services from. So once we were having our participants come in and for many of them get their first rapid testing with us here, in some of the studies, we started thinking about how could we do self-testing at home for them in between study visits so that we would not have to have them come back in, but they could complete their own test in between visits and report those results. We have trialed at-home self-collection tests that would then be mailed in, as well as actual just rapid self-tests. In regards to the home collection mail-in, we had a number of issues. One, especially, and I'm talking about our teenage participants, they were less interested in testing that required that they collect blood specimens. And so oral specimens were more acceptable in that particular circumstance. And even when they would do some dried blood spot collection, they wouldn't always be run in the manner that they're meant to be. One thing that I always kind of laugh about is that, particularly for the mail-in collection samples, we would have some of our youth say that, you know, they've never mailed something before and are not sure how that would really work for them, not sure where a mailbox is. So those are things to think about for sure. And we've had, and I'll speak to this in a minute, but we've had much more success with rapid, like OraQuick, OraSure products. We've looked at what does it look like to, you know, oftentimes standard of care does not include at a testing center or a PrEP center, does not include text messaging for appointment confirmation or rescheduling or even reminders for visits or daily adherence. We've looked at studies that implemented those strategies and saw you know, marked difference between in visit adherence and PrEP adherence when, as opposed to not implementing those strategies. Finally, we've actually been looking at some of the same projects that Erin was just speaking around about implementing mobile app-based HIV and PrEP services through research studies. And we've found through the Adolescent Trials Network ITEC studies that some of these mobile apps can really make a difference in helping young people get connected to local services and stay on those services. Next slide, please. So if you are going to be implementing, whether it be HIV self-testing or PrEP access with young people, these are some things to consider. As I mentioned before, you want to make sure that you have a strong web and social presence. If you are, I imagine, at a larger institution, you probably have a department and some staff that handle that for the whole institution. If you're maybe at a smaller health center or community-based agency where maybe you have a part-time person kind of running your social media, that is still very important. And you want to choose a topic that will relate to your audience and post about it regularly. So whether that's resharing other content, creating original content, but something that, at least that we've heard from our youth, when they are evaluating whether an agency is trustworthy, you know, when was their most recent post? How often do they post? Do they get engagement on their posts? Like, do the fans and viewers of those channels actually engage with them over social or not? Those are not necessarily things that you think about when you want to build a quality healthcare service and program, but it is the way young people think and view things. And in regards to the kinds of messages that you put out, especially for young people, we want to emphasize, you know, pro-social health over and well-being over risk messaging. We don't want to scare youth away around, hey, if you've never had a test before, think about it, versus, getting tested for the first time can be a good experience, come with a friend, get tested together, that kind of thing. Now, every state has actually different laws around at what age minors can access and consent their own STI and HIV screening and treatment. So that is something that's very important to look into your own local laws. And as of now, I think something Rupa had mentioned earlier, the CDC has put out a really great letter around self-testing. However, we really only have one approved over-the-counter test product, and that's the OraSure or a quick test. And their company also has an age limit on what they think is an acceptable practice for how young you or old you can be before you can use their test. So these are all things to consider. Given that this would be implemented, self-testing and PrEP programs would be implemented in some variety of a telemedicine approach, as Erin was speaking to, you want to make sure that your agency is using a flexible but secure online data collection service, and that ideally has some built-in communication channels for your patients or clients to speak with the service staff on your end. Every step of the way should have some digital media aspect for education around instructions. And some examples that I can include here would be, whether it's a quick infographic or comic that breaks down the steps involved and how Erin was describing earlier, the process it takes to go from getting tested through actually walking out of a pharmacy with your prescription or having it, arrive to your home. We really need to break that down for young people and work with their level of patience around what it takes to not only start PrEP, but then stay on. And if we can illustrate that or record video and share that with them, that's all the better. Now, even around mailed packaging, in particular for youth who live, who might live with their parent or guardian or other adults, caretakers, packaging should be discreet. So, whether that's an Amazon box or USPS standard post box or envelope, something that doesn't scream there's an HIV test inside, is ideal. And I can talk through some of our experiences around that. Next slide, please. So here are two, and if you can click through so that the videos pop up. Here's just some examples around what I meant by providing digital media resources to your clients or your youth clients or youth participants. There are already quality, you don't have to recreate the wheel, you don't have to create original content from scratch. There are quality educational resources on the web. The first is a video from ASAP Science on YouTube. It's essentially an HIV/AIDS 101 video done in a digital illustration that is what we provide our participants who sign up to get tested through our research study prior to them even receiving their test. So they're already learning about, it's a parallel of sitting down for an HIV education and counseling session before getting tested. And OraSure, the makers of the OraQuick test product, also have actually a series of digital media videos on their website, hosted on YouTube, for how to run their test and what how to interpret the test results and what to do if there's reactive tests and they want to follow up on that. And if you could move through this. So those videos, just to make it clear, those videos are resources that we provide to our participants via our study portal, so on the website, and as well as in email communications that they receive. So they have like long-term access to that. It's not that they receive it once and it's gone. They can continue to go back to those resources. Now, when we package our test kits for mailing and delivery to our participants, we include some print test instructions. On the left, you'll see a diagram that's actually provided by OraSure, and it's just a very kind of almost cartoon, simple illustration on the steps that you have to go through to run the HIV test. And on the right, you have also from OraSure interpretations of what they might see on the testing window and interpreting it as a non-reactive, reactive, or indeterminate result. If you could click through that. So those are also resources that are posted on our study portal as well as on the email communications that they receive. On the left, you'll see a chart from CDC that breaks down the differences between rapid self-tests and self-collected tests that they would then have to mail back to a lab. It's a neat infographic that you could choose to use in as resources that you offer. I know that these slides are going to be shared, so I've laid out a number of links to other resources on some of the topics that we were just speaking to. In particular, the CDC sexual health resources on basic education and also access to finding local services near them. These are resources that we provide to our participants via, again, the study portal, but as well as in the email communications that they receive, making sure that they have multiple touch points and checkpoints on things that they may need, given that this is a, kind of like a telemedicine approach where they're really taking charge of their own health and participating on this HIV self-testing study. If you could move forward. So I wanted to speak to you a little bit about Keeping It Light. Keeping It Light is the NIAID-funded epidemiology study of HIV. This is a national prospective cohort study. We screened about 12,000 people on an online pre-screening tool posted to social media and LGBT mobile apps, and identified around 5,500 eligible people. They had to be 13 through 34, cis men, trans women, and gender nonconforming persons who were HIV vulnerable based on their sexual behaviors. Ultimately, we enrolled 3,500 participants, and you can see the breakdown by gender and age group on the table. So it's largely a group, it's largely a cohort of cis men, but there is about 25% transgender and gender nonconforming persons. And our median age is actually about 24, so it's almost 50%, 24 and under, and 25 and through 34. And if we can look at the next slide. And if we look at our sexual orientation by age group, you'll see it's also largely a group that identifies as gay primarily. However, there's another 25% or so that identify as queer or bi. And if we can look at something that I think is interesting to note about young people is it's more likely actually, at least in the sample that we recruited in this cohort, that they identify as bi or queer versus gay. And that might be something to think about if depending on how you are marketing and building the program for the clients that you want to reach. If we look at the cohort by race and age group, we see that it was about 50% white and 50% split between Latinx, Black, and other. Next slide, please. Now, when we look at the age and PrEP status or PrEP, use status of this cohort, something to note is that we can see, and so this is a sample that was recruited between December 2017 and December 2019. So in those 2 years, we see that of these 3,500 persons, the older the group is, the more likely they're on PrEP. And that's, following national trends, so it's nothing that should surprise us. But when we think about the, EHE goal of increasing PrEP utilization, we can easily see that youth are a primary target for increasing PrEP. And if we could move forward. So based on having enrolled this cohort, we've now been looking at some new areas of interest. And in the last year, of course, been looking at how has COVID-19 impacted the lives, health, and well-being of this cohort. We ran a survey in May and then again in September, asking some particular questions that I'll go through on the next slide. So out of a group of about 2,000 total respondents, 25% of them told us that they had trouble accessing regular HIV testing services. So I broke this down for you by age group and then their responses. So the majority of the group said that they had not tested based on being less sexually active. And there was a bit of a difference between the youngest of them and the oldest of them, in that the youth actually were reporting less sexual activity. But then if we look at other issues around whether they did not test based on having access issues or financial concerns, or even to avoid exposure to COVID-19, we see that those were actually a little higher in the 25 and up group. They were less a bit of a concern for our youth. And there was even, a smaller percentage, but anywhere between 2 and 8% of folks who reported that they did not test, they could not test, but even though they felt they may have been symptomatic for HIV or an STI. And if we could move forward. We also asked them about what had their PrEP use been impacted during this time period. So out of that same group of about 2,000 participants, 571 reported that yes, they had some issues with their PrEP use. I broke this again down by age group and then what they reported. So we see in blue here that something between 40 to 55% of them had continued their PrEP use as normal, but about a quarter to a third even did continue, but they reported challenges, and those challenges were that they had stopped taking it daily, so they were taking it a little bit less than daily, based on being concerned that they wouldn't be able to renew their prescription on time. And then a smaller percentage reported that yes, they did pause, and that was because again that they were less sexually active, and again there was a difference between the youngest of them and the oldest of them. And finally, there was a smaller group as well that reported that they had paused based on issues with access and finances. Next slide, please. So we asked them, given that there's been impacts to regular healthcare, in particular in this case, routine HIV screening and access to PrEP, we asked if they'd be interested in telemedicine, and by and large, most people are saying yes, we'd be interested, and we would utilize telemedicine if it was available to us. There's a little bit of a difference between the 15 to 19-year-old group and the 35 plus, where there's a little bit more uncertainty of interest in accessing the telemedicine. And I think, again, that goes to some of the points made earlier around, especially for our youngest of participants who may not have a very well-established relationship with primary care, may not have the need or motivation to routinely access primary care. I think telemedicine, although we should be very excited at the evangelization of telemedicine and what it could do for healthcare around the country, we may have to tailor and make sure it's designed adequately per population. And with youth, it may be around educating them around what does telemedicine really look like? What does it really work like? They have an idea of what does it look like to go into a doctor's office, but sitting at home in their bedroom, imagining what a video call to a doctor may look like may be something that we may need to or want to do some education around. One last slide, please. So in the same survey, we allowed for some open-ended responses. And I mean, I'll read just one quote, but in general, I wanted to emphasize that there is desire for and general support for telemedicine. Our first respondent said, a mobile STI HIV testing unit would be a good idea. I live in the city, and it would be a good way of limiting exposure if I don't have to travel to testing clinics. So there, in general, a lot of the responses were around, if I don't have to go somewhere, then that would be convenient and ideal. And if that means that I'm limiting or reducing my exposure to potential COVID-19, then that's an even better, package deal for me. Yeah, so that's one last slide. I just wanted to thank my research team here at Cook County Health, our funders, and all of the participants of Keeping It Light, and also to NASTA for having me here today along with our other panelists. Thank you so much.
Thank you, Pedro. This model is great. We can surely learn a lot from this going forward. So I'd now we have about 8 minutes left for a couple of questions and any open discussion. So feel free to use the chat function if you are most comfortable that way, or if you like to unmute yourself and please pose any questions you'd like to the presenters here. To kick us off, though, I do see a couple of questions here in the chat. I think this first one was during Rupa's presentation, if she is still on. Do you anticipate any pushback or denials from insurance companies if adapted the initiation of PrEP is used?
Hi, can you hear me, Kendall?
Yes.
Yes, so something we did not talk about for the sake of time is kind of the other factors related to self-testing. So first, it's what are your state regulations for testing? And then in that framework, who can deliver tests and order them, et cetera. And lastly, you brought up a good point, is what's covered and do programs have funding? So at this point, molecular diagnostics does have a system to integrate everything into your EHR, your electronic health record, and also insurance companies can cover the labs through molecular diagnostics.
Thank you. And again, please feel free to use the chat function or unmute yourselves if you have any questions for the presenters here today. We did also receive a couple of questions during registration, and they may be a little bit repetitive from maybe some discussions that you had during some of the presentations, but there was a question about finding information on formatting community engagement. Can either of the panelists speak about formatting community engagement for people to hop on to PrEP or community or avail themselves to self-testing?
I'm not sure. This is Pedro speaking. Can you? I'm not sure if this is a direct response to that question, but something that we've trialed. If you are just starting a telemedicine self-testing PrEP access approach, start with your clients that you've already have in your program, right? Once you have a program ready to go, reach out to them, let them know it's available. Let them, utilize it and take advantage of it, experience it for themselves. And have your champion, clients be your best advocates. We had a lot of success in having our participants actually refer, friends, family, partners, peers, et cetera, to the self-testing program. Something I didn't mention earlier was, in particular for youth and self-testing, it was often their first test they'd ever done for themselves was the test they did on their own. And so it's really a pretty remarkable educational experience to guide a young person in what it looks like to do self-testing, and now instill in them this value of self-care for that they can carry for themselves throughout the rest of their years. But yeah, in terms of community engagement, work with the community you're already engaged with, and have them be your champions and advocates.
Thank you. Looks like we got another question from the chat. And it says, great information, the clinical aspects of PrEP and TelePrEP. My question is on the front end registration and payment process for uninsured or for telehealth services. Can you provide some resources or sites that have been developed for or through the telehealth process? Thank you in advance.
This is Rupa. I can comment on the reimbursement and billing, etc. So resources are on the following websites. The Prime Health website that I've directed you to in the presentation, as well as Illinois Public Health Association has been doing a lot on HIV-related billing, HIV treatment and prevention-related billing, and telehealth. And in general, most telehealth regular billing sites will work, or information sites. And this goes back to the first question I had answered as well. PrEP is under the umbrella for prevention. So please don't forget that first. And you will, for every extra visit for follow-up or just engagement, it does fall under prevention, and that should have no pushback from providers. I'm sorry, from insurance companies.
Thank you, Rupa. And with 1 minute left, there was one question that I have not heard before, and I'll see if we can squeeze that in. Has there been any talk of progress with Ready Set PrEP being available to dispense at tribal pharmacies?
This is Rupa. I don't have enough information on that.
This is Aaron. It's an important question. I also don't have information.
Indrel, maybe we can check in with our colleagues at HHS and send out the response to that question to the group.
Most definitely. So we are right at time. So I'd like to thank CDC, the presenters, and of course, participants for joining today's webinar. Our contact information is actually on the screen for each of the presenters and here at NASDAQ. Oh, that's also on. Thank you so much for joining today's webinar, and have a great day.